Hello, welcome to our video about treating the wrist and the forearm. There's a lot of mechanics in here, so let's get started with muscle energy to warm our brains up. So for the interosseous membrane myofascial release, remember we have the ulna on the ulnar side going to the fifth digit here, and the radius, okay? Your radial head is actually right here, and if you move the forearm, you can feel that twisting in here. And we'll get into the mechanics after these MFR treatments. So you can generally contact the interosseous membrane right in between those two bones. You can stack your fingers here, or if you find a localized spot you want to treat, you can put your thumbs together. However, this covers a lot of good ground. So I'll go with this. You can check superior, inferior, medial, lateral, even twisting clockwise, counterclockwise. So she's got bind here. I'm gonna treat direct here, yeah. So I'm shifting up medially and in a clockwise rotation to do myofascial release. And then as it releases, I'm gonna continue that fascial creep. You doing okay? Yeah. Okay. And then after about 30 seconds to a minute, we reassess, okay? And then you reassess those motions again, okay? For the carpal tunnel, you can put your hands behind the back of their hand, and you essentially want to check those same directions as you did in the interosseous membrane. And you're really doing wrist extension here as well. So bind and bind. So it's a little different than the interosseous. It's more of a tight space, okay? Now if you wanted to turn this into more of like a soft tissue, you can interlock your pinky with their thumb and your pinky with theirs. This creates a long lever stretch as well. And then you can also do this stretching motion here. Really, I'm kind of creating space under that retinaculum, and you can just continue to do some rhythmic extension as well. Maybe you're checking ABA deduction at the wrist. Doing okay? Doing some circumduction here. Have fun with it, right? Okay, so that's myofascial release. And then we recheck here with a little bit of soft tissue. All right, counterstrain, long head, short head. The long head is gonna be a little bit more lateral, so you can remember it that way, long lateral. But in that bicipital groove here, is that tender here? Yeah. So that's gonna be where your lateral head is. Long head. The short head is on the coracoid process, which is like a little bony prominence. If you find your AC joint and just go straight down, you're gonna find this bone right here. Is that tender? Yes. She is more short head tenderness. It's gonna be flexion, adduction, and internal rotation. So let's say she has some long head biceps. You say tender, yes, let's call it a 10. Then you bring them up. They sometimes will call this the damsel in distress pose, right? And then I recheck. How does it feel now? Better. Let's call it like, less than a 3 or less, hopefully. Now for the short head, you're on the coracoid process again. If you want to come up close and see. You feel that, huh? Yeah. She's actively wincing, right? This one, you can actually come in flexion across the body, kind of like that. And then this is external, we want to do internal. And I'll feel it soften there. How's that? 0. Woo, we did it. All right, and you hold 90 seconds, turn to neutral, recheck, okay? So that's bicep. All right, next is gonna be the supinator, or the lateral radial head counterstrain point. You're gonna find it laterally. So radial head being here, and generally you'll find it right there. Is that tender? Mm-hmm. Yeah, so what we do is we bring it out, we extend that arm like so, and then we will do some supination. So we bring it full supination. I'm gonna press there again. Is that a lot less tender than it was? Less than a 3 or less out of 10. And then we hold it there. You can also use your leg for some support, so they're not flopping in the breeze, right? You want to secure your patient for counterstrain. Now, if we were to do pronator, which is going to be more towards the medial aspect of the arm, that's going to be flexion and pronation with adduction. So that point is right here, and it can be pretty tender. So yeah, flex, adduct, pronate. Want to come closer? Look at my finger. There we go, right in there. Better? Yes. 3 or less, good job. Reassess. We have the extensor carpi radialis right here. So that point is right at the base of that thumb here. So you push here. Is that pretty tender? Yeah. Yep. So what you do is you can bring the wrist into, and you actually switch hands. So do it here. You can grasp along here, along their hand, and you're bringing that wrist back towards that point. Got some extension, abduction, and a little bit of radial deviation. Better?
Yes.
Yeah? Okay. So that's the point for the extensor carpi radialis. Now, for the next one, extensor carpi ulnaris, it's right here, right on the ulnar side. How is that tender? No? Let's find it. Yeah, right here. Okay. So similarly, extend, abduct, deviate towards the ulnar direction. Okay. Is that less?
Yes.
Yeah. 3 or less? 0? Okay. So that's those two. Next we have the flexor carpi radialis, which is on the flexor of the palmar surface. It's right here. Is that tender? Yes. And then we bring it into flexion, abduction, and radial deviation here. And then we fold over. Is that still tender? No? Okay. And then we wait 90 seconds. Now for the flexor carpi ulnaris, this point is on that ulnar surface here. Here's the pisiform bone, and it's on this distal attachment site right in here. Woo!
Yeah.
She feels that. You're going to flex, and then you're going to adduct and ulnar deviate there. All right, and now what is that? A 0? Okay. She's just saying that, but it's okay. We're demoing. Ta-da! We have a forearm attached to our student, Genesis here. So for the forearm mechanics, you want to remember that supination. All right, so this is supination of the hand and wrist, and this is going to cause the radial head to go anteriorly. We have pronation, which is going to cause it to go posteriorly. Okay, can you supinate your foot for us? Supination of the fibular head goes posteriorly. Okay, so that's different. Supinate or pronate. So yep, so pronation of the foot. This goes anteriorly for the fibular head. So just think, this is totally opposite from the forearm, okay? So since we're treating the forearm today with some muscle energy, a couple things, right? You're kind of giving them a handshake, okay? And your thumb is gonna be on the radial head, either in front of it or behind it, based on where you're trying to push it back into place. So let's say this patient comes in with a posterior radial head, okay? So that means they're going to have preference for pronation, okay? So to get it to go anteriorly, this way, we want to put our thumb underneath it and push it up this way, or anteriorly to the body. And we take our forearm and supinate it to its supination barrier, okay? So as I'm asking her to go back into pronation, because remember this is PIR, I'm also pushing on the radial head to push it back this way. So we push, we rotate into supination. All right, try to turn your hand over. 3, 2, and relax. And do that again. 3, 2, and relax. And do it again. 3, 2, and relax. One more time, and good. All right, now if we're treating, let's say she has an anterior radial head, she prefers pronation, we do the opposite. We hook our thumb around, we try to push the radial head posteriorly. So she probably actually has more of an anterior radial head because it's so tender right here. And we're gonna ask her to supinate. So as I push down, turn your hand over, 3, 2, and relax, and then do that again. Good. You see how much force I'm really using with my thumb here? That's doing a lot of the work, and it doesn't feel great if you're in the right spot. So just be aware of your patient's, tolerance. And again, 3, 2, and relax. And one more, 3, 2, and relax, and final stretch. So that's how you do muscle energy for a radial head dysfunction. Hello, we're gonna do muscle energy for a wrist dysfunction. So really remember, for the wrist, extension, flexion, and then you have to turn it over this way, right? Adduction, abduction, okay? So let's just treat in this position because it matches with anatomical normal and it makes the directions a little easier to think about. So let's say the patient fell like this and their wrist is stuck in extension. Well, you want to do just like that MFR hold that we have, but bring them into their flexion barrier here, and then you ask them to extend. So extend your wrist and relax. Remember, this is PIR specific. And go again. So they're contracting into their ease positioning or their diagnosis, and relax. And then one more, and relax. And you do that same sequence, right? If they have, let's say they fell like that, which is kind of crazy how to fall. But for, let's say, a flexion dysfunction, you bring them into extension and then try to flex your wrist and relax. and again, and relax, and then one more, and relax. Same thing goes, let's say if they have an adducted wrist versus, ooh, that clicked, versus an abducted wrist. You just bring them into that barrier and have them contract towards the ease. So let's say, yeah, she's a little bit more restricted this way. So she is, let's say, adducted at the wrist. So bring her into abduction and try to bring your pinky that way. And relax. Do that again. 3, 2, and relax. One more, and relax. We're at that anatomic end barrier, right? And so I'll just do a little, just clicky a little bit. In this, we're gonna be treating a distal capitate or trapezoid bone, okay? And these bones are somewhat close to that thumb joint here, so they're right here. If this needs to be put back into place, if you have a displaced bone here, you wanna put your thumbs right over it, and it's like a whipping motion, okay? So what we do is we bring it into that slight extension barrier, okay, with both our thumbs stacked, putting a pretty decent amount of pressure into that bone, and then as you get there, right, it's a quick thrust down, okay? And then you reassess. Does that hurt anymore? No, it doesn't hurt at all. So we're treating an anterior radial head with HVLA, all right? So this one, if you watch dodgeball, right, they're like, think about that. That's like the positioning we want, okay? That was really bad, but so you want your thumb in front of that radial head because it's anterior, you want to push it back posteriorly. So you're here, and the motion is, you're like dapping her up, right? You're like, what's up? And then you're pronating the arm, okay? So you're here with your thumb. This is your fulcrum. This is what you're like thrusting into. Technically, this is a long lever approach to HVLA for the radial head. And so as you're flexing at the elbow, you're pronating, and the thrust is kind of this push towards the shoulder while keeping a lot of pressure at this thumb. So she's wincing because it's very tender there, all right? So again, it's quick. As we get to that barrier, it's gonna be a quick thrust like that, okay? And you might not hear a pop or click. Again, for HVLA, that doesn't mean it wasn't effective. And ready, and thrust. Okay, so it's a quick back against this. Some people you might see use this method against their MCP here, but I don't get as good localization. I like to use the thumb. Now let's treat a posterior. So it's a little different, right? Because you're bringing it into supination and extension. So if it's posterior, it's stuck down, you want to bring that into a supination barrier as well as use your thumb to go anteriorly, all right? So the thrust is more of like a combined this plus your thumb, all right? So as we get here, and then it's like that, okay? So it's a combined thrust, like that, okay? Just don't hyperextend the patient's elbow too much, especially if they're hypermobile. You can cross that anatomical barrier, maybe cause some elbow problems, so you just wanna be right at that feather edge barrier with that quick thrust like that, okay? And then we reassess. Woo. All right.